Ladies and gentlemen, welcome to part 2 of our presentation. This is where it gets really exciting because we are going to talk about the pressed ceramics. This is new materials that are available on the market today. Now, the pressed ceramics encompass 2 special groups, and the groups are Empress 1 and Emax. So we're going to talk in detail about where and when to use these materials, and so we can be aesthetic and functional at the same time without getting into trouble.
We will also touch bases on the one body group, which is a unique part that we added to the classification, and the high strength ceramics such as zirconia, the monolithic full contour zirconia based restorations, when and where is best to use them. So far, all what we have talked about earlier were porcelain veneers. But really, what about crowns, or full coverage restorations? And we're going to go through the indications and the longevity and the masking abilities of different ceramic materials. The best indication for a crown is when you want to replace a crown. In this instance, it's a full mouth of porcelain fused to metal restorations that are breaking down, and obviously the best way to restore this case is by using full coverage restorations. Now, you might think that we are insane talking about a material that is pretty not in the market anymore, which is Dicor. Dicor is a material that is very weak and it's very translucent. But there's something to be learned from the history. Kenneth Malamed has used these materials over 20-some years on about 1,400 restorations. And he placed them on the anterior teeth as well as on the posterior teeth. And the outcome was, the interesting part of it was that really on the anterior teeth, he had a high success rate, even though the material was weak, and oftentimes he did not even bond these materials. While on the molars, he had a very low success rate. So the general trend, or what we're finding from these results, is that really the location of the tooth in the arch makes a big difference in terms of longevity. Anterior teeth behave very differently than a posterior tooth. In terms of the forces that are encountered on an anterior tooth, it's about 25 pounds. When we go to a premolar, it's about 70 pounds. And a molar is 10 times more than an anterior tooth. So the location of the location of the tooth in the arch really is a factor in determining what material to choose in the clinical situation.
So we are beginning to see a pattern. And what is that pattern? That the demand on the anterior teeth is low, so aesthetics is of paramount importance. But then we shift over to the posterior teeth where the demand increases in terms of function and load, and aesthetics becomes less important. So we always have to keep these 2 things in mind, aesthetics versus function, as we're comparing anterior and posterior teeth. So let's summarize now when it is that we are going to use these feldspatic porcelain restorations, okay? So the first time we would use them is for single teeth only. We would never use them for fixed partial dentures because they're just not strong enough. Then we need to have adequate tooth substance available. If there's not enough tooth structure underneath, it's not going to work. It will break because these restorations get their strength from the underlying tooth structure. They will simply have a higher risk of cohesive failure. They can easily crack within the body of the restoration. So it must be bonded. What else? The underlying tooth structure must be not undiscolored. It should be a normal color, normal natural tooth color, because these restorations are fairly translucent. And the translucency means that they will show whatever is underneath there. So you cannot use them for implant restorations when we've got a titanium abutment or a gold abutment underneath, because that is hard to mask. These restorations allow us to control the opacity and the translucency within the same mass. So we can put the mini wings in, we can put translucency in, we can blend the restoration in other areas. So we can do a lot of tricks to deceive the eye with one material, the powder liquid of feldspathic ceramics. We again apply those internal effects and then block the black shadows that we've gone into quite a lot of detail explaining. It can also allow us to blend in the surrounding dentition, and obviously what we've already discussed is that please do not use these restorations on titanium or gold or any kind of metal or discolored abutment, because the technician will never be able to block that properly with these restorations. They are very translucent. Just think of it as like a frosted glass. It's as simple as that. So the next domain within the one body group is the pressable ceramics. And the pressable ceramics can be subcategorized into two groups: the lucite reinforced, or Empress 1, or the lithium disilicate, or Emax. And I will talk to you about the lucite reinforced, and Dr. Aloom will talk to you about the Emax, or the lithium disilicate. So what exactly is Empress 1? Don't we want to know that? Well, let's take a look at the SEM of this material. Under high power magnification, we can actually see what this material looks like. Take a look at those slides. We can see these round particles on the screen that are embedded within the glass matrix. What those are these particles called the lucite. What exactly is lucite? Lucite is basically this filler, and it fills up about 45% of our restoration, and it gives it some strength. The way you think about it is basically like a group of people within this room, and as we got a crack going through the restoration or going through this room, we are the individuals that are placed inside the room. Just think of us with a room full of people, and each one of us is a lucite crystal. So as this crack is coming through the room, we can stop, block it, and prevent the crack from going through. Just think of it that way, okay? And that's what gives us the increased strength compared to the feldspathic porcelain. So we now take a look at a high-powered magnification of the lucite reinforced material, but after etching. This can be etched for about 90 seconds for the hydrofluoric acid that we've discussed, okay? But the etching, what it does, it etches out the glass and leaves those craters that you can see there for the resin to go in, and the resin allows the bonding and also allows reinforcement of the ceramic. And look at those arrows, they're pointing at the craters that I'm talking about, the red arrows. So, are there any clinical studies that show us if this actually works? It's good and well talking about materials and what they look like and sound like and what they do in the lab, but is there any clinical evidence to show the efficacy of these materials in patients' mouths? In 1994, there was a study that looked at these restorations, and guess what? Molar teeth, fairly high failure rate, 24%. We go to premolars, it drops down. We go to central incisors or anterior teeth, it almost drops down to 0. Isn't that interesting? What we discussed with feldspathic ceramics is now being applied to the lucite reinforced material. So now let's look at another study. This was done in America or the US. The following study by Fradiani is done in Europe. Let's see if teeth behave differently, if materials behave differently in another continent. Fradiani, quite enough study, 11 years of data, and what he found was that on molars we had a 13.4% failure, but when we go to the anterior teeth, I bet you already know what that's going to say. It's going to be almost 0. Anterior teeth have a much lower failure rate simply because there's a lot less load on it. So we have to be very careful how we select these materials in terms of load and function that's placed on the restoration. But one thing that must be stressed is that these restorations were all bonded. They were bonded to the underlying tooth structure. That's how they get their strength, by gluing them or bonding them to the underlying tooth structure, and that prevents that crack initiation that emanates from the underlying structure. So keep that in mind. And if we don't have proper substructure underneath, like in a situation like this, it will be madness. Really, it would be crazy to put an all ceramic restoration on there, because it will simply crack cohesively. It will break through the ceramic restoration itself. We need good, solid tooth structure to support the restoration anatomically. Okay, and that's what we will show you the core material will provide for us in future slides. So in summary, the Empress 1 should be used really for single anterior teeth only, not much more. Okay, we need to have adequate tooth substance available for bonding. That is also important. Must be bonded. We've already discussed that. What's underneath has to be undiscolored, because if it has any type of color or discoloration, it will show through. That also applies to implant abutments. So if you have a titanium abutment underneath your restoration, the whole thing will look gray. So be very careful of that problem. So the pressable ceramics can be classified into the two groups, the lucite reinforced and the Empress 1. We've discussed the Empress 1. And now Dr. Aloom will discuss the lithium disilicate, or the Emax.
Emax restorations are becoming more and more popular nowadays in 2011. And we really have to understand the chemical part of lithium disilicate to understand the limitations of it. As Mamadi described earlier about lucite reinforced and the issue with the crystals and the glass, the same goes for lithium disilicate. Crystals in lithium disilicate are elongated. They're not rounded anymore. They're elongated, prismatic. And they are about 70% of the whole volume of the room. Meaning that if we have a room, 70% of the room are the people. And those people are the crystals in a way. And the crystals, as we said earlier, that they're going to make the restoration stronger. They're going to deflect crack. But at the same time, they're going to make the restoration transmit light less. So, also with Emax restorations, you have to layer with a special kind of veneering structure or a powder and liquid, which is most of the time called fluoroapatite ceramics, fluoroapatite glass ceramics. Now, Emax come in two forms. It's either pressed, as you see the yellowish part of the screen or the ingots, and it comes into the form of milled ingots, which are the purplish, bluish blocks, where you can probably just basically put them in a machine and they can mill them into the full contour. Now, Emax can be also fabricated in 4 ways. And the first 2 ways are the milled or pressed into the full contour, where you can stain them and glaze them. And that puts it into the category of the one-body restorations, where most of the time you would rather use this option for posterior teeth, where aesthetics is really not much of a prime importance, and function is the main factor. And we also have the other issue where you can mill or press into cutback version, or a partial restoration, a core, and then afterwards you can layer on top of it the fluoroapatite or the powder and liquid ceramics to get better aesthetics, which most of the time is going to go into the anterior sextant or the anterior teeth. And you see here the different forms where you can press it into the cutback version and then layer on top of it the incisal effects and the halo and the translucencies and so on and so forth to get a beautiful result. Now, in terms of light transmission of Emax, how do Emax really behave under light? And what you see on the screen right now is 3 different types of restorations. On the right side of the screen, you've got the porcelain fused to metal, which you see the cross section of it. It's blocking the light completely. On the other side of the screen, we've got the lithium disilicate or the Emax, and you see the amount of light that is transmitted through the restoration. In the middle, it's the porcelain fused to zirconia restoration. And you see the zirconia blocks the light probably halfway through. So those restorations actually are really translucent. And this study, which is a recent study in 2011, where they evaluated the effect of the abutment color on the outcome using Emax restorations. And the outcome of this study really is that whenever you use the ingots which produce or have the lowest opacity or the highest translucency, they're called the LT ingots or the low translucency ingots. Really, it's absolutely impossible to block discolored abutment, just like you see in the picture. So these restorations, you have to be very careful when you try to block dark abutments, because they really transmit light fairly efficiently. This is a case where we have used lithium disilicate, partial coverage, and some occlusal onlays using Emax restorations. And we just measured the thickness of these restorations, and you see the thickness is about 0.6 millimeters. And once you just shoot some light from the backside of those restorations, you see how much light is transmitted. I also try to put a black rod right under those restorations and just fired some light, and you see how the black rod is actually showing through this restoration on the other side of the screen. This is just to prove that really those restorations are very translucent. This is a cross section of a SEM of lithium disilicate after it's been etched, and just to remind you of the elongated prismatic crystals. Those are like, probably you can say, the Lakers, where they're long and they're strong, and they constitute about 70% of the restoration. And you really have to etch Emax just for about 20 seconds. When you etch, you remove the glass part of the restoration, and the glass part only is about 30% in these restorations. So please, not more than 20 seconds etching with hydrofluoric acid. Now, what about clinical studies? Is there anything to prove that these restorations actually work in the oral environment? And actually, there's quite a bit of studies that have been performed on those restorations. To start with, this study in Europe, where they evaluated fixed partial dentures or bridges using Emax. They try to push the envelope here. And over 8 years, really, they had 2 fractures of 36 bridges. And we see the nature of the failures. Most of the time, they are on the connector's side. Again, another study evaluated also bridges or fixed partial dentures over 4 years. And they had about 4 fractures over 30 bridges. It's still a quite high number, and I wouldn't like that to happen in 4 years in my practice. And really, the success is a bit on the lower side. And please just note the dimensions of those connectors. They're very big, and they make our restorations really less hygienic, and they're really not biologic, or not even, they don't even look good. Now, this study, which is actually compared how those restorations behave in terms of full coverage, crowns, and fixed partial dentures or bridges over 5 years. And really, crowns behave very well with these restorations. However, fixed partial dentures are really not a good option for those restorations. 100% success for crowns. Now, the other issue with Emax, which a lot of people are trying to evaluate now, is do we have to bond these types of restorations, or can we just basically just cement them using any type of self-etching cement? And Edelhoff evaluated these restorations over 4 years, where some of those crowns he adhesively cement them, and some of them he just conventionally cement them. And really what he shows that really bonding is not required. Now, unfortunately, I wouldn't like to make a solid statement that bonding is really not required. It's still a question mark. Probably more and more studies are going to come up, but it's a very attractive option that really you don't have to bond these restorations, especially on the posterior areas where sometimes really getting isolation is very difficult. So let's look at this case where lithium disilicate was used as an early experimentation of this material. It's a full mouth reconstruction where you see on the anterior part of it, we've got a fixed partial denture, a pontic site, and lithium disilicate here has been used as a two-body restoration, pressed into a partial core, and then afterwards fluoroapatite glass ceramics was layered on top of it for aesthetics. You see, everything was done very nicely, and the restorations look fairly okay in the patient's mouth. But lo and behold, after probably about a couple of weeks or so from the delivery, the fracture took place right at the connector of the fixed partial denture. Still on an anterior site where occlusion or where the forces are not really of a prime issue, but still this material seems to be very weak with fixed partial dentures. And upon removing or trying to remove this fixed partial denture of the mouth, trying to cut through it, you see the clinician went through several burrs just to show you how this restoration is very hard. And afterwards, the case has been restored with our working horse of dentistry, which is porcelain fused to metal, because we know that porcelain fused to metal work best in fixed partial denture cases. So let's summarize when and where is best to use Emax or lithium disilicate. Number one, it has to be used on single anterior or posterior teeth. No fixed partial dentures. You have to have some tooth substance because this material, as we said, it's weak and it gains its strength from the underlying substructure. So most of the time you have to bond it. Now the question of conventionally cementing it is still under the under the experimentation period of time. We cannot really make a solid conclusion yet, but it's something to think about. And because these restorations are really translucent, we cannot use them on highly discolored abutments or titanium abutments on implants or gold abutments because they're very translucent. So, what are the advantages of pressable ceramics? When would you use them as a clinician, or why would you use them as a clinician in general in your private practice? And the advantages are four. Number one is the marginal integrity. Light transmission is very similar to the tooth structure, and we can control shape on substrate, and it has a high success in the anterior area. And to go through each one of them, really, the marginal integrity of these restorations or pressable restorations, and in particular Emax, is phenomenal. With the regular powder and liquid ceramics, where you want to get good marginal fidelity, we've got the inherent defect of the material it shrinks upon firing, and every time the technician has to refire again, and it shrinks, and you have to refire again, and you have to have a fairly skillful technician to be able to use powder and liquid ceramics. But for pressable ceramics, an average technician really can get very good marginal integrity and fidelity. In terms of light transmission, these restorations have very similar light transmission to tooth structure, to dentin, and that's why it's really nice to use these restorations, especially when you're combining between different substrates in the same sextant. For example, this picture over here, you see there's an implant restoration right on one of these teeth, and the others actually are restorations of veneers. And you see the similarity of light transmission between those restorations.
So you can see that we've talked about pressable ceramics and how they can be useful in everyday restorative dentistry. But what pressable ceramics also allow us to do is to control shape, as you can see on the screen, and the substrate to be able to deliver definitive shapes that patients need to look at and approve and then copy for final restorations. Okay, and this is an example that will allow us to demonstrate that. So take a look here. We are on the screen over here. We have a patient who has a big maxillary defect because she had a traumatic injury due to a road traffic accident, a unilateral defect that needs to be restored, as well as a central incisor that needs to be restored with a porcelain laminate veneer. What this technique, the pressable ceramic, allows us to do is to copy a wax up into a provisional, and the provisional is tested in the mouth. You can see we've designed the provisional restorations in such a way that it looks exactly like the final. The only difference is that the material is different. So what I mean by that is that we have a substructure which is going to be made out of a ceramic material which will be delivered for the patient, and individual crowns which will be delivered on top of that substructure, and also a veneer is going to be bonded onto the patient's tooth. Again, the provisional and the final will be the same. We go through a phase where the patient approves and tests out the provisional restorations in her own mouth. And once she's agreed to the fact that this is something that she would like and it's acceptable, then we go ahead and deliver the final restorations. Now, one thing that I'd like you to pay attention to is the issue of material thickness. In particular, to do with this veneer, look at that single central veneer and look at the amount of space. We have at least about 1 millimeter of space between the natural tooth structure and the outline of the restoration. And what that allows us to do is to deliver the restoration on the tooth and the implant restorations all in one visit. However, if that area or the thickness of that veneer was any less than 1 millimeter with these pressable ceramics, then we have a problem with translucency, and the effect of rehydration of the underlying tooth will have an impact of the final outcome of the restoration and the final outcome of the general shape and form and aesthetics of those teeth. So we do not need to allow for rehydration of those teeth simply because the material is really thick. So let's take a look at what we do with the implant restorations. With the implant restorations, we have a framework that is a copy of our provisional framework. Those individual restorations are sprued, and with the lost wax technique, they're invested and ceramic is pressed into the ingot. The ingots are pressed, and we have restorations made out of ceramic. These are cut back and layered like you would do with a two-body system. With a slight bit of staining, you can see that we can get very nice aesthetic restorations on both the central incisors, and then we can follow it through to the other side, to the laterals and the canines. Again, an aesthetic result can be delivered for our patient simply by following some basic principles and understanding the properties of the material, the translucency of the material, and you can see we've avoided the fact or the problem with rehydration simply because we understand that the veneer is thick enough so that the underlying substructure will not have too much of an influence in terms of rehydration. Let's take a look at another situation. In this particular instance, a patient presents with teeth that have been broken down, kind of similar to the previous case, but obviously the defect is a little bit smaller. But in this instance, the volume that needs to be added is minimum. It's minimum amount of volume that needs to be added to the natural teeth to be able to restore aesthetics. And so the veneers are going to be thin. So immediately you will start to think that if that's the case, if the underlying tooth structure is going to play and have an influence on the final outcome, what we need to do is that allow for rehydration of the teeth before the single unit implant restoration is delivered for the patient. So before we go ahead, we go and make a wax up, and the wax up really is based on proper aesthetic principles, And this was done by Michel Magnier. You can see the patient before and after. It's all done in stone models, so we can really see the outline and the shape that we're trying to deliver. Again, the lingual aspect or the palatal aspect is just as important as the buccal aspect, because that affects the way we see things, the way that it breaks down the line, and it is absolutely essential that we respect that both in the provisional and in the final restorations. Now let's take a look at the patient at this stage of treatment. The stage I'm talking about is when the veneers have been delivered on the maxillary left side, and the veneers have been delivered with the single unit provisional restoration on an implant on the picture on the left side of your screen. You can see that with the minute we put some light inside the patient's mouth, because we have different substrates, and because the different substrates have different optical properties, the restoration actually looks different with that type of light in the patient's mouth. And so what we need to do is that we need to make sure that we use the right type of ceramic material so the optical properties are the same and it looks fantastically beautiful in all lighting conditions. That is our aim. And right now what you can see is that the veneers have been rehydrated on all the natural teeth, and for the single unit implant restorations we've made a zirconium abutment that has been customized with ceramic on top. The ceramic has been placed on top of that zirconium abutment after the rehydration has occurred on those veneers. So we will match it exactly to that base shade, so nothing is left to guesswork. And really the rest of it is fairly straightforward. All we need to do is make a pressable ceramic that goes on top of that material, and we go to the final. So you can see the patient before and after, and with a series of steps, we've managed to deliver aesthetic restorations in a predictable manner. But try and remember the sequence of steps that are different in this particular instance, because the veneers were thin, we had to allow for rehydration, compared to the previous instance where the veneer was extremely thick, so we didn't need to allow for rehydration of the case. Let's go back to our classification again, the one body and the two body. And now we're finishing off on the one body system, and particularly we're going to focus in on this high strength one body material. And this material gives us a little bit more range of what we can do with these ceramic restorations within, at least within the one body group. What it allows us to do is three things. The first thing is that if a patient comes in and they request a tooth colored restoration, and we have limited space in a high force area, what is it that we can do? How can we predictably deliver restorations for our patients? Well, this gives us that option. It's called the all-in Z, or a full zirconia crown with nothing layered on top. Okay, and this was shown in a nice case developed by Bruxa. You can see that they look fairly acceptable in the posterior region. They're very strong, and they can look tooth colored as well. So it is a good option for these patients. Now, you may think, wait a minute. If we deliver these types of restorations, zirconia is a really hard material, isn't it? Well, if it's really hard, what it's going to do is going to wear the opposing tooth or the opposing enamel. That will create a problem for us. Isn't that right? Well, luckily, Dr. Young had already thought about that, and he's done a beautiful study that actually compared three different groups. What are those groups? Group number one is basically a group that only has feldspatic restorations that are glazed against natural teeth. Then he has a second group which has polished zirconia restorations against natural enamel. And the third group is glazed zirconia restorations against natural enamel. And he put these in a grinding machine, start testing the wear characteristics of the enamel, and to see which one performed the best. And guess what? The best performance was, surprisingly, with the zirconia group that was polished. Isn't that interesting? So we can use this material against natural teeth, and as long as it's polished nicely, it doesn't damage tooth structure much at all. It will be pretty much the same or better than a normal PFM that is polished or glazed. So one more thing that we need to talk about before we start doing this type of restoration extensively in our patients' mouths, we need to think about one other issue, and that issue is an issue that has been raised, or a question that has been raised only in laboratory studies, but we need to be aware of it before we use this extensively in patients' mouths. And that is the issue or the concept of low temperature degradation of the zirconia. So basically, zirconia can degrade and start breaking down in the patient's mouth in the presence of water over a long period of time in normal mouth temperatures if it is not protected or if it's not glazed. So we need to glaze the zirconia really if we want to be sure that that is not a problem. So that's something that we need to keep an eye on, and we need to basically watch this space and see how the research develops in this area. So to be safe, really, what we need to do is to polish our zirconium restorations and then even glaze them to protect them, to stop the breakdown on the actual zirconia. So we protect the opposing teeth and we protect the zirconia restoration from breaking down. So please join us for the grand finale, Module 3,
where we're going to discuss the two-body group and talk about the high-strength core all ceramics, such as probably the most famous now is the porcelain fused to zirconia, and also the porcelain fused to metal restorations. When, where, and why would you use these restorations?
For more education programs, visit the Guide Institute at www.guidedental.com.